afternoon, good morning, welcome to wherever you are. My name is Patrick Habecker, and I'm a research professor here at the Rural Drug Addiction Research Center at the University of Nebraska-Lincoln, and I'm absolutely thrilled to be here today to talk with you all about policy and substance use across the United States, but also, if we get into it, wherever our panelists want to discuss. What we're going to do today is basically introduce the panel itself. We're interested in this simply because drug policy is effervescent. It changes a huge amount of how we think about drugs, how we think about substances, how we react to them, how we treat people who use drugs, the laws we shape, and our ability to react to changes in both the substance use supply as well as a host of other factors. So we are joined today by four wonderful panelists to talk through this. The general format of the panel will be, we'll have the panelists introduce themselves for a few minutes and then go through some pre-curated questions that we've sort of been talking about with ourselves, and hopefully are going to be a fantastic discussion. And then we'll open up the floor to the audience. If there's questions that you want to see answered or addressed, we'd love to have them, and we'll open that up a little bit later. So I'd like to start by asking each of the panelists to introduce themselves, talk a little bit about their backgrounds, perspectives on the topics. If you're interested, why you were interested in willing to volunteer to take part of your day to join this panel. Would love to hear it. And I'm just going to start on order from my screen. So Erin, if you're willing, are you happy to sort of introduce yourself first?
Sure. I'm Erin Winstanley. I'm an associate professor at West Virginia University. And I'm also the vice chair of research for the Department of Psychiatry. So I've been doing research related to substance use disorders for about over 20 years. By training, I'm a behavioral health services researcher. The majority of my work over the past several years is really focused on how to reduce the morbidity and mortality associated with the opiate epidemic, and also investigating how we can use technology to improve engagement and retention in behavioral health services. So more specifically, I've been really interested most recently this past year in really investigating the problems that are being caused by fentanyl in initiating buprenorphine treatment in patients, as well as investigating how opioid overdoses may result in cognitive disorders. I'm also a co-investigator of the Appalachian node of the NIDA Clinical Trials Network. So if there are a lot of interesting projects going on there, and as many of you know, West Virginia has had the highest rate of overdose deaths in the entire country for the past 20 years. So needless to say, I'm fairly passionate about drug policy. I was really thrilled to be invited to speak on this panel and actually be able to dedicate some of my time to drug policy work, which I feel like I increasingly don't have as much time to do lately. So I was really excited, not to mention the fact that there are so many important, pressing issues going on right now, and so many exciting things to talk about. It was hard to actually pick the list that Patrick provided us as some of the questions. So, and I'm really honored to be on this panel with my other colleagues from across the country. So thank you.
Fantastic. Thank you, Erin. Jennifer, you're next on my list, if it's okay for you.
Yeah, hi, my name is Dr. Jennifer Mills-Price, and I'm actually in the southern part of the state with Dr. Winstanley in West Virginia. So we share a border with Eastern Kentucky and or Southeastern Ohio. So we're a pretty, a small city of a little bit under 50,000 and surrounded by some pretty rural communities. And we share a lot of the issues that other small communities in the United States face. We have a struggling economy, high rates of obesity, chronic pain, other chronic health issues. Also, a lot of illicit substance use, which results in high rates of neonatal abstinence syndrome and overdose deaths. I'm a psychologist by training and clinical assistant professor at our medical school here in Huntington. I've worked with our Department of Psychiatry and Behavioral Medicine for the past 4 years, and I'm really happy because this is my first kind of public presentation, having moved to our Division of Addiction Sciences in our Department of Family and Community Health. So I'm really excited to be here with everyone. I have worked with individuals with substance use disorders for quite a long time now, since about 2008 in different capacities, both as a clinician, as a treatment provider, and also as a forensic evaluator and an expert for the child welfare system in West Virginia. Part of what brought me to Marshall is Healthy Connections. So this was a community coalition that was established in Huntington in 2016, and a group of agencies in the area that work with families affected by substance use, particularly mothers with substance use and their children who've been prenatally exposed. And what we've accomplished in the last 4 years is to establish a child care center with specialized training and caregiver training for children who were prenatally exposed to substances. Also to establish a pretty robust, at this point, family navigation program. I like to refer to these folks as freelance case managers because they get to follow the family as opposed to belonging to a certain agency. So if patients switch clinics, that's no problem at all. And also to help install peer recovery coaches in various areas such as emergency rooms, our neonatal treatment center, both our outpatient and our inpatient, and other like outpatient substance use treatment locations. What our future directions are, what we're working on right now, is to streamline our research program, provide training and mentorship to other communities, particularly in Southern West Virginia. I'm sure Dr. Winstanley understands there's a lack of available treatment there. So we want to help with some of those communities. And also advocacy targeting judges, attorneys, and guardians ad litem, working with families with substance use disorder.
Fantastic, and thank you. So Magdalena, you're next on my list, if that's all right.
Hi, everyone. Thank you so much for joining today. I'm Magdalena Cerda. I'm a professor in the Department of Population Health at the NYU Grossman School of Medicine. I also direct the NYU Center for Opioid Epidemiology and Policy. I'm trained as a social epidemiologist, and I do research on the social and policy drivers of substance use and violence. More recently, I've been doing work looking at opioid policies, particularly those that aim to regulate the prescription opioid supply, those that increase access to harm reduction efforts, and those that affect access to treatment, and how they impact opioid prescribing, chronic pain, and overdose. We're also looking at the impact of marijuana legalization on different forms of substance use and related harms, both in the United States and in other countries, in particular in Uruguay in South America. And we're interested in how opioid policies and marijuana legalization intersect to affect pain, opioid prescribing, and opioid use. So that's something that we're increasingly looking at. In addition to that, we're also interested in looking at these emerging policies that are arising across the country. So we're going to start to evaluate the impact of Oregon 110 decriminalization policy in collaboration with Corey Davis at the Network for Public Health Law and the CDC. So I'm really excited to be here today and to be talking about some of this work and to be talking about this with some of the leaders in the field. Thank you.
Fantastic, thank you. Brandon, you are last on my screen.
Yeah, thanks so much, Patrick. I'm thrilled to be here this afternoon. I'm zooming in from Providence, Rhode Island, where I am an associate professor in epidemiology at the Brown University School of Public Health. I'm a substance use epidemiologist. I focus a lot of my work on understanding the epidemiology of overdose. I've moved over the last several years to focus more on the evaluation of novel interventions to prevent overdose. A couple of studies right now involving primarily harm reduction tools like fentanyl test strip distribution. And I also work with Magda as well on another intervention study that we're just rolling out here in Rhode Island to try to use machine learning methods to predict neighborhood level overdose burden and work with community partners in our state health department to try to identify those neighborhoods most at risk and provide resources in an efficient and effective way. I'm also very interested in how we use data and scientific evidence to inform policy or not. I'm the state director of our overdose data dashboard, preventoverdoseri.org. And I also am an expert advisor to the state's overdose task force here in Rhode Island. So I've seen firsthand, very fortunate to be able to witness some of that process through which data, scientific evidence inform at least state policy. I also have served as an ad hoc advisor to the Drug Safety and Risk Management Advisory Committee at the FDA and have learned a lot through that work in terms of federal policy in this space, particularly around new drug approvals and opioid-related policy. So I am thrilled to join my panelists and jump into some of the questions you prepared for us, Patrick.
All right, thank you again to everybody for the introductions and for being willing to join us today. So as a reminder for those attendees, we're going to work through some questions that we've been sort of workshopping a little bit first, but there is an opportunity for you to ask your own questions throughout. We're planning to get to them a little bit later on, but feel free to add them to a chat or Q&A as they come to you, and we'll try and get to them. So the first question is that we talked about as a group. So in the past 2 decades, we've developed a number of policies to address the overprescription of opioids here in the United States. Looking back now, reflecting on this, was this a successful policy approach or did we go too far? We're seeing increasing claims that patients can no longer receive adequate pain relief, and as well as charges that reducing legal options. So by reducing the ability of people to prescribe and the access has pushed a large number of people into the illegal market for opioids. Our first.
I can take that. I take a crack at that. I think the evidence is mixed. I think we have some evidence from evaluations of opioid policies adopted in different states that, for example, adoption of comprehensive prescription drug monitoring programs that proactively provide authorized users of the PDMP with information about outlying dispensing and prescribing patterns so that they can actually use the PDMP data to respond adequately to potentially inappropriate prescribing, as well as laws that regulate pain management clinics and to prevent high volume dispensing that might be diverted to the illegal market. We've seen that those kinds of laws are associated with a reduction in high dose and high volume opioid prescribing. And they're also associated with a decline in overdoses involving prescription opioids. So in that sense, we'd say, those are a success, right? At the same time, we have seen potentially some unintended consequences in the sense that we've seen that some of these laws are also associated with an increase in overdoses involving heroin and illegally manufactured synthetic opioids like fentanyl. And so in that sense, I think it highlights some areas for concern. But I wouldn't say that means that it is not a success. I think it means that to address a problem as complex as the opioid crisis, it's not a one component solution, right? We need a multi-pronged solution. So at the same time as we're trying to pass these laws to regulate inappropriate opioid prescribing, we also need to invest in efforts to increase access to evidence-based treatment for opioid use disorder, increase access to harm reduction efforts, and increase both research and access to evidence-based treatment for chronic pain, because we know that at the same time as we're addressing this overdose crisis, people live with chronic pain every day and they lack the tools to manage that pain adequately.
Yeah, I'll jump in here. I think those are fantastic points, Magda. I think one way I think about this, Patrick, is that perhaps there was not a sufficient focus on understanding incidence versus prevalence. Perhaps if there had been some more epidemiologists at the table, we could have started from this framework where we obviously want to prevent inappropriate exposure or incident cases through reductions in overprescribing of opioids for minor procedures or acute pain conditions. So that, as Magda said, is happening and is working to some degree. The issue is that those perhaps were those same policies were misapplied to people who were currently experiencing opioid use disorder or were in chronic pain. We saw adverse consequences of many of these policies in that population of people. And I think we still don't have a very firm scientific foundation to understand how to appropriately engage in patient-centered tapering and other novel pain relief modalities as well. So I think that's where we as a nation and even as researchers missed the boat to some degree, was understanding that we have a large number of people, over 2 million people, who currently have opioid use disorder. And we don't want circumstances where policies really designed to prevent initiation or incident cases are having adverse consequences on that prevalent group, which unfortunately I think is what happened over the last decade.
And I completely agree with Brandon and Magda. I'd also add, I think some of the evaluations of the effectiveness of these policies have been difficult, right? Because they've been differentially implemented across states and are used, right? And states have different levels of resources in which to fund these efforts. So I witnessed that dramatically when I moved from Ohio to West Virginia, right? There's significantly fewer resources in West Virginia to, monitor the PDMP and use it as a tool, as opposed to Ohio. And at the time I left Ohio, they were spending $1 million a year, the state was, on overdose and prescription drug monitoring efforts. So, and that budget is simply not available in West Virginia. So, but we definitely have a good idea that it is working, as Magda's already mentioned, and that some of those key elements that have made some of those policy and regulatory changes effective. I think that's what's become, less clear to me, and perhaps other panelists have a different perspective, but it's almost more the unintended consequences of this increased monitoring and the punitive sanctions associated with potentially overprescribing that have created sort of this fear among not just prescribers, so doctors and nurses, but even in the news yesterday was a report from NPR, and Dr. Price in West Virginia may have seen this, right, about the DEA cracking down on pharmacies for dispensing buprenorphine. So, I think when we split this question up, Patrick, is, overall, you framed the question as in, these opioid policies or opioid medications. So on the one hand, with prescription pain relievers, there's definitely evidence, but what has been the unintended negative consequence to other prescription opiates like buprenorphine used to treat, opiate use disorder, and that unintended consequence is pretty substantial. It was quite a dramatic report for those who didn't see it in the NPR just the other day. So where a pharmacy really they're starting to turn away patients and not dispense for fear of these DEA and not their regulatory crackdowns, I guess. So I think it's hard to monitor. And, in a state like West Virginia, what's really challenging, right, is as we've been able to use SOR money and other federal funds to increase access to buprenorphine treatment, that means we need more pharmacies, right, to help dispense those prescriptions. And so, of course, there should be upticks in the amount of buprenorphine products they're dispensing, but how to sort of not get them tangled up in these the sort of automated systems that, that are looking for, increases that might be problematic. So.
I'd kind of like to add kind of a provider perspective to touch a little bit on, like, phenomenologically what some of these patients experience. I noticed in the comments someone's mentioning that as well. So I worked for a comprehensive pain management clinic that included mental health treatment, behavioral health treatment, primarily provided through group therapy, behavioral chronic pain management, as well as supportive counseling. And also we have a psychiatrist that is on site about 4 hours a week to deal with comorbid depression and anxiety, which is very high among individuals with chronic pain conditions. A lot of the folks that made it to our clinic did so because we were the only game left in town. We did have a lot of providers that were writing a high volume of prescriptions for opioids who, as regulations were being enforced, kind of took their shingle and left town. And so we had a lot of people who are very elderly, have multiple comorbidities, both psychological and physical, who all of a sudden were in acute opioid withdrawal. And also had an untreated chronic pain condition, and for many behavioral health condition, because also those prescribers were giving benzodiazepines to a lot of patients, whether they were indicated or not is for another day. But what we've really had to work through with a lot of patients is this feeling that they are now being viewed as a drug addict, through no fault of their own. And again, there's some cultural factors that play into that. We're a rural area. A lot of our patients are particularly rural. They may drive 2 hours each way to our clinic, from an area in which, there is no psychologist in their county, for example. And so we're placing an uneven burden on the patient as opposed to being able to provide those resources that Dr. Winstanley was talking about. We're already upside down in West Virginia in terms of behavioral health. We don't have enough psychiatrists. We don't have enough psychologists. That gap will likely not close in the next 30 years. And then we're adding this patient population to treat, and the resources were not provided when those decisions were made. So I do think a lot of patients felt abandoned, and processing why these changes were made and how could this come to happen, that you develop a physical dependence on a medication without any ill intent. Processing that has been part of the treatment that patients have felt a lot of relief for their self-judgment and depressive symptoms.
Just waiting to see if there's other comments on that. And thank you for catching the comment in the chat. I think we're going to, unless someone wants to immediately address this, I think we're going to come back to this at the end, because there's some really interesting implications there about who gets to make these decisions and how do we invite people to the table. So we might move slightly unless there's other comments directly on it. Okay. Yeah,
I can just say from my experience, they hate it. Siphoning chronic pain patients into the OUD care system, that is something we had more access to in our area. We have MAT clinics that they would be eligible to enter, but because of just the psychological consequence of thinking of oneself as a pain patient one day and then suddenly a drug addict the next, I think that's difficult for a lot of people, particularly elderly people who've lived a very pro-social lifestyle.
All right. So sort of the second question that we have on the list in sort of this section of the panel, increasingly we're seeing this term called the poison drug supply. I feel like a few years ago, this was something that I saw in activist circles or on drug research Twitter, but now is increasingly in the media, it's in the news, it's being used more. And it's being linked to ever increasing deaths from overdoses in the US. Could the panel talk a little bit about what this is referring to what extent has policy led to this current situation, and what are some of our options to reduce overdose deaths in light of what we're calling a poison drug supply?
Sure, I can take this one, Patrick, first, if you like. The way that I think about this is that it's a highly uncertain drug supply. People do not know what they are using. The potency varies tremendously. The type of cuts, the adulterants are varying, and this continues to be a problem, not just in opioids, but in stimulants as well. And so one more acute immediate way to address the problem is to provide information to people on what are in these substances, and so that they can make more informed decisions about their risk reduction practices. So I think that's where we've seen a lot of interest in drug checking technologies, which aim to do exactly that, right? Which establish either the presence or the concentration of some substance like fentanyl to give people that information and encourage engagement in risk reduction practices. So that's one thing. I think also, we'll maybe get into this a little bit later, but thinking about the environment in which drugs that have highly uncertain composition are used is critical as well. So changing the actual environment in which these drugs are used is another way to reduce overdose risk through the provision of naloxone or supervised consumption spaces, which we'll think, talk about later. Stepping back for a moment in terms of how we got here, we have taken the approach in this country of deeming some drugs illegal and then highly criminalizing people who use them for the greater part of an entire century. And what we have seen is that has not worked. And that's not a subjective statement from me. The data shows that we've had an exponential increase in drug overdose deaths for more than 3 decades. And so at this point, I would argue strongly that we will not see a fundamental shift in that trajectory until we rethink how we choose to regulate these substances. The exact way in which we do that, I do not have the answer to those questions. I think this is one thing where we all need to work together and try to come up with a more person-centered and compassionate and public health focused approach to regulate substances, because what we have been doing clearly is not working. So that's a call to action for everyone on the panel, particularly the students, to start thinking more broadly and maybe looking to other countries for broader solutions to address this very complicated and complex issue.
I would say, I think the poison drug supply, right, more often than not, is really referring to illicitly manufactured fentanyl. So, and it's really important to think about some other tandem legislation that's going on right now. So it's really hard, given that fentanyl analogs and the precursor chemicals can be easily shipped across the country through the mail. It makes interdiction efforts very difficult. So there's a lot of, I think, disagreement on how to stop the flow of fentanyl, these illicitly manufactured fentanyl analogs and precursors into the country. And so we had a temporary ban on a class-wide ban on fentanyl compounds that was really, identified by some folks in the DEA as a fantastic policy, right? So that you don't just ban fentanyl, but that if you ban the whole class, then we can prevent those analogs from coming into the country from places like China and other places as well through the mail. Unfortunately, when we do these class-wide bans, it also means that we haven't done the research necessary to investigate these compounds. We don't really know much about them. Most of what we know about fentanyl is based on pharmacodynamic and pharmacokinetic studies on pharmaceutical grade fentanyl. So we really have had limited opportunities to truly understand the abuse potential and also any therapeutic benefits of these compounds. And just because they're in the same class doesn't mean that they have the same drug effects. So it's simultaneously, we implement these policies like a class-wide ban to prevent interdiction, but simultaneously could be tying our hands behind our back to be able to identify new products to reverse overdoses from these highly potent fentanyl compounds like carfentanil, and it becomes really complicated and how we move that forward.
Yeah, I would say that, the increased prevalence of illegally manufactured synthetics is driving the overdose crisis has led positively to an increased focus in harm reduction efforts. And so states, almost all states have passed laws to facilitate access to naloxone. Many states have passed laws Good Samaritan laws to protect bystanders who call for help. And there's increasing, even in the federal overdose prevention plan, mention of fentanyl testing strips. And so all of those things, I think, are quite positive in terms of preventing deaths from overdoses involving fentanyl. But I would agree with Brandon that, in a way, while this is a very positive move, it is a little bit too little, and that we're going to have to keep with these kinds of short-term responses until we do something more broad and cross-cutting, like thinking about decriminalization of all drugs. Because only by thinking about decriminalization of all drugs will we be able to, first of all, regulate the safety of these products, and be able to ensure that people who use drugs have access to the services that they need, both in terms of how they use and in terms of treatment, if they're interested in treatment. And those really are going to be the essential services that we need in order to prevent people from overdosing and prevent people from dying from overdoses. So, and I think we're going to talk about Oregon in a few minutes, but hopefully we're going to be moving towards a more broad-based approach to thinking about drugs.
Fantastic. So I think the next question that sort of builds a little bit in line for this is that, Rhode Island is set to become the first state to officially sanction safe consumption spaces in 2020. I believe in March is the date for when the first one can open. And this links directly to a lot of what we were just talking about with this idea of a poison drug supply or an uncertain drug supply. So can we talk a little bit about what is a safe consumption space trying to accomplish? What is this policy trying to do? The gaps it's filling in, at least in the US, but also what does it fail to address? We just talked a little bit about, these are small steps. Is this a complete step? Is this a final step? Or is this just one more piece of a policy puzzle here?
Yeah, I can take that one, Patrick, and then I'd love to hear from the other panelists and their thoughts. So supervised consumption spaces or safe consumption spaces, we're calling them harm reduction centers here in Rhode Island, typically have a number of public health goals. One is immediate, which gets back to my earlier point around changing the environment in which drugs are used to be safer. So we know, in fact, that overdose fatality is 100% preventable. If someone is present, if oxygen and naloxone are present, overdoses can be reversed. So death does not need to happen. So the one key purpose of these spaces is to provide that safe environment to avoid overdose death. The second goal is typically a little bit broader, and that relates to the fact that many people who use drugs have been highly criminalized. Many, let's be honest, have had horrible experiences in our healthcare and addiction treatment system. They've been discriminated against. And so many are very reticent to access existing services. One key feature of these spaces is they aim to be low threshold, low barrier, truly meet people where they are at, allow that consumption to occur, but through that process, build rapport with folks, connect people to peer counselors or nurses or addictions counselors, start to repair those relationships, those clinical relationships and those service relationships, and over time, connect people to things like treatment, recovery resources, housing supports, and so on. So that's a little bit of a longer term goal, a slower process, but what we have seen from evaluations in Canada around the world is that it works very effectively, and that people who use these services are more likely to engage in treatment and recovery services as a function of this relationship building process that happens. I want to emphasize that's truly critical in a lot of these spaces. They rely on relationships. I think one thing to keep in mind with supervised consumption spaces is that they're not a panacea necessarily, and at the end of the day, they are going to be most effective in places with high levels of overdose and where there are many people particularly who can access them. We know that most people who do live or reside within a mile of where they're physically located. So I'm actually not sure how appropriate these kind of interventions may be in more rural areas or even suburban areas. I think that's where we need some more innovation around how to provide these kind of services in those settings, whether that's through technologies. There's another set of programs called Never Use Alone, where people can be connected over phone and be almost like virtually supervised. So there could be other innovations in this space to provide services outside of a brick and mortar facility, which typically are in larger urban centers with a high concentration of people who would benefit from these kinds of services.
I think that's really interesting, Brandon, actually, the thought about how do we increase access, essentially, how do we increase access to harm reduction services, right? And so thinking of safe consumption sites as one type of intervention within a broader package of interventions to increase access to naloxone for people who use drugs, as well as people who know people who use drugs, to increase access to ways to test the drug supply, to increase access to clean needles. And then in terms of safe consumption, again, thinking about different ways to do that in different kinds of areas. So I really like the idea of thinking what are the types of systems that we need in different kinds of settings within this country. And I haven't seen, I think, a lot of discussion about that. So that seems like a really interesting area for future investigation.
So let's shift gears very slightly here. We've been focused mostly on opiates to some extent in our discussion so far. But, there's one of the biggest changes in the past 20, 30 years has been the regulation of cannabis and marijuana. There's now 18 states that have recreational use laws passed and 36 that have medical. And each of these states has sort of implemented their recreation and medical market a little differently. They're changing or handling supply chains in different ways. So what do you think we have learned so far from this new regulated market? What should states and the federal government be thinking about for establishing new markets? And have we seen evidence of how this shift from a completely underground market to regulated either for medical or recreational use, how has this affected other parts of society in these states or in some of the other countries that we know across the globe that have made these moves?
I can take that. Yeah, and again, I would love to know what others think about this. I think, it speaks to this broader issue that we were talking about before about within the area of decriminalization and regulation of the supply. So in particular with cannabis, I think one of the main drivers for legalization was to protect people from involvement in the criminal justice system for misdemeanors related to possession and use of cannabis, and particular to reduce racial and ethnic inequalities and involvement in the criminal justice system. And I think, that's a very important aim of these types of policies. So far, there have been many studies that have tried to evaluate the impact that legalization of medical and recreational use of cannabis has had on health, particularly on drug use. So far, we've found that particularly legalizing recreational access to marijuana is associated with an increase in use of marijuana among adults and an increase in cannabis use disorder among existing cannabis users. And potentially there's some evidence that suggests there might have also been an increase in co-use with other drugs, including alcohol. So in that sense, we balance all of these different goals that we have. The potential increase in use may be an unintended consequence of some of these types of laws. However, I don't think this means that we shouldn't legalize. I think it just means that we should think about how we legalize marijuana. So if you think about tobacco and alcohol, right? There are also products that we know are harmful to our health, and yet they're legal. And we've learned a lot about how to protect people's health by regulating tobacco and alcohol. So what I would like to see with marijuana, and I don't think we're seeing yet, is learning from particularly tobacco about how to regulate marijuana safely to address those unintended consequences. I think, states should really think about packaging of the product, what types of labeling in the packages, safety and potency of the products, location of retail outlets, investment in prevention programs, particularly to reduce early initiation of cannabis use among adolescents, since we know about the long-term risks of that. I also think we can learn lessons from what's going on in other countries. So for example, in the United States, while states differ in the ways that they've legalized cannabis, they've all adopted a highly commercial approach to legalization. That is, where there is relatively less control over the product, right? But there are other places, like, for example, in Uruguay, in South America, that was the first country to legalize as a country recreational use of marijuana. And they've adopted a very different approach where the government regulates the type of product that is produced, the potency of the product, who sells it, and how you have access to it, and how much you have access to. And so, that's another extreme of the approaches to legalization. And so I think by comparing what's going on in places like in Uruguay and what's going on in the United States, perhaps we can identify those types of approaches to legalization that are most protective of public health while still protecting people's rights and reducing racial inequalities in criminal justice involvement.
Yeah, just to pick up on one of such a good point you made, Magda, I would proffer that addressing racial ethnic inequities should actually be one of the primary goals of a lot of these new laws and decriminalization regulations. What I fear is that what we have been embarking on is a system where racial ethnic inequities might actually be exacerbated, because if you're not addressing the historical harms upon which racialized communities have faced by far the burden, and at the same time are creating a commercialized market where only a certain segment of the population is benefiting, i.e. those people with access to capital and engagement in that market, you could very quickly actually exacerbate existing racial ethnic inequities, right? So what I would really love to see in a lot of these measures is more of a focus on addressing some of the historical harms, whether that be through a reparations framework or at least a focus on expungement of past convictions. Because what I don't think we want to see is people continuing to suffer the consequences of criminalized cannabis or other drugs, be that challenges accessing, employment, student loans, housing, while other people make vast profits off a newly legalized product. So, I'm looking forward to learning more in our discussion around Oregon, around how that state might be addressing some of these issues. But I do think as a society, we need to put more, policymakers need to put more focus on this.
I just wanted to also elevate a point that Magda made, because it's just so important, right? Implicit in her comments is who financially benefits, right? We've already been down this road with prescription opioids and the pharmaceutical company with these ongoing lawsuits. So really this, she's presented this opportunity to say, how are we doing this here compared to other countries? And really asking a question of who financially benefits, because part of the issue will be, even as we develop these policies to better regulate, which her comments were just so dead on, I agree with them, and so eloquently stated about we need that regulation piece on recreational cannabis products. But when you say who benefits from that and the financial, financially from that, it may influence, unfortunately, that regulatory process. So I think really it would really behoove us to, as she recommended, look at other countries and other models as we move forward, and more states probably continue to move towards recreational cannabis.
We may discuss this in a bit more detail later on, but I'd like to add, from my point of view, a concern I have in West Virginia's implementation of medical marijuana is the disconnect between the kind of the legislative language and what might be enacted in policy, particularly with the child welfare system. And I do think that, even though West Virginia is a predominantly Caucasian state, in my experience, I've seen differential prosecution of child welfare cases with African-American families. Even legal opioids, we still have an issue with those being perceived in a very negative light by certain judges or the CPS workers in certain counties. And although the state laws are in keeping with public health, how they're actually implemented is not often. And so I do see, being aware of potential unintended consequences of something that by and large could be very good. But there may be some areas in which, these kind of the two sides need to communicate with one another a bit more. I noticed with New York, when they recently passed a decriminalization legislation, they also included in that some child welfare language, but not all states have done that. And I know in Colorado and I believe Washington State both, someone can still have a child welfare case, even consuming marijuana completely legally. So that's something that as a state that's kind of at the beginning of that process, I have a concern about.
Sorry, I was on the wrong tab when I tried to unmute myself. There was a lot going on there, and there was a couple of different points to take from this. And I think let's shift slightly to Oregon. It's come up a few times. We're talking about large-scale regulatory schemes. What have we learned from prior regulatory changes, such as tobacco? Alcohol is a fascinating shift. But just last year, we witnessed this really large change where the state of Oregon passed Measure 110. To effectively decriminalize personal possession of all drugs that we typically consider illegal. And now people found in possession of those substances either now pay a fine or go to a drug treatment center instead of jail or prison. It's a complete diversion from that criminal justice outcome point. And this is a really marked departure for drug policy in the US. This is a really large scale. It's not substance specific. So is this sort of things that we're thinking about and coming out of these conversations? What can we learn from Measure 110? Do we think we'll see similar measures in other states? And what do you think this type of effort brings to substance use policy, as well as things to maybe watch out for as 110 enters its, I guess, full implementation?
Yeah, I think it'll be really fascinating to follow this, right, and to see what happens in Oregon following the passage and enactment of 110. I think it's really, as others have said, it's really a historic moment in drug policy. What I really find interesting is the shift from focusing on criminalization of drug use to essentially focusing on public health and the need for investment in treatment and harm reduction efforts. Because essentially that they are proposing to use funds from taxes and for money that would have been funneled to the criminal justice system and diverting those funds into treatment, including investment in services such as triage, case management, linkage to care, mobile outreach, peer recovery, as well as overdose education, naloxone access, and access to syringes. So I think particularly this investment in increased access to treatment, as well as the shift of thinking about treating drug possession from a misdemeanor to a lower type of violation, that you can actually either pay a fine for or have that fine waived if you agree to take a health assessment is pretty historic. And so I think we're going to have to see what happens in terms of the health of people who use drugs following the enactment of this measure, what happens to overdoses, what happens to access to evidence-based treatment for opioid use disorder, and other types of substance use disorders. What happens to arrests, right? I think those will be all important outcomes. And we will have to really carefully think about, again, this same theme that we've been talking about who benefits from this law, right? Are there racial ethnic inequalities in the impact that this law has? Are there income inequalities in the impact of this law, particularly with this $100 fine that you would have to pay for drug possession? But I think overall, it's a really great opportunity to learn and to think about approaches that shift from criminalizing people who use drugs to thinking about the types of services that they need to live a harmonious, safe, and dignified life.
Yeah, fabulous points, Magda. I don't have much to add to that. You summed it up so well beyond the fact, I think, that we should listen and learn about this Oregon experience, listen to the people who were able to successfully push for this measure and learn from the evaluations that I'm sure are forthcoming. I would, to get to one of the parts of your question, Patrick, I would hope and anticipate that we would see similar efforts in other states. I think one thing this does, I've learned about recently, is this idea of this Overton window, which is the window that defines the range of policies that are acceptable in sort of mainstream discourse. And one thing that something like Measure 110 does is it expands that window, right? So hopefully, by Oregon passing this measure, that makes this perhaps like palatable, at least as an option to be discussed in other states or ideally at a federal level. So I think we shouldn't estimate the impact of just even one state passing this kind of historical measure because of the spillover it has on the other conversations and debates across the country.
I agree, Brandon. It's such an exciting time, right? I would have never said just 5 or 6 years ago. I mean, I think it was probably more than a decade ago that you weren't really allowed to put harm reduction in any of your federal grants, right? And so we're really starting to see this change, and not just a few states, but being able to talk more openly about harm reduction, syringe exchange programs. And the truth is that we are not doing a fantastic job, right? The war on drugs is absolutely a failure. Overdose deaths continue to increase. And so we really need to explore new innovative models and reprioritize treating people that use drugs compassionately and help keeping them safe. So I think it's really exciting to be able to see what's going on in Oregon, what's going to be happening in Rhode Island, and hopefully really learn from those sooner rather than later, in particular about what's working in those states and how we might tailor that or modify those programs as they expand.
Absolutely, all good points, and it continues to be interesting to see these steps, right? The Overton window is a great point. You used to be able to talk about decriminalization. You had to talk about Portugal or Spain or another country or Vancouver, right? And someone will always say, hey, that will never work in the US. But now we get to see. Same thing with Rhode Island with the harm reduction centers, right? So very exciting times. So in line with just sort of that last bit, Erin had that nice comment about, it used to be you can even put harm reduction in your grant application, but just recently the U.S. Department of Health and Human Services released a new overdose prevention strategy focused on 4 areas where they list explicitly primary prevention, harm reduction, evidence-based treatment, and recovery support. So is this evidence at the federal level that this is a new effort that's signaling, in a right direction? Are there new elements? Is this going to be a real change, you think, from the federal end or federal policy that may trickle down into states? And, what's still missing from this? Is this still just yet another small step, or is this the potential for something new?
I think there were a lot of great things in the Department of Health, the U.S. Department of Health and Human Services overdose prevention strategy, namely the mention and the support for harm reduction efforts, as well as the prioritization of increased access to evidence-based treatment and removal of administrative training and financial barriers to treatment. I think those were a real important shift from what we've seen in the past. I think one area that I wish had been addressed is thinking. So we focus a lot on treatment. We focus a lot on harm reduction, which is great. I would also like to see more of a focus on primary prevention and essentially thinking about fundamental causes of drug misuse and of experiencing harms from drug use. And so thinking about social policies, economic policies that should be prioritized to address this overdose crisis. We've seen with COVID, right, that we've seen more people die from overdoses than ever before. Now, part of that is likely because, of the fentanyl drug supply, because of decreased access to treatment, because of decreased access to harm reduction. But part of it is likely because of, the economic crisis that has shaped the pandemic. And so thinking about other types of policies like housing policies, eviction moratoria, income supplements for families, all of those kinds of social welfare policies that reduce social and racial inequities are likely also part of what we need to do to address this crisis. And I would hope that in the future, federal strategies also think about that.
Yeah, I completely agree, Magda. I thought, it was interesting to compare this with the Biden administration's approach to climate change, which seemed a bit more of a whole of government approach. My understanding is that each department is tasked with identifying how their work may be impacted by climate change and how they could address climate change. I wish I had seen the same thing here. It's like more engagement with other departments, agencies within the federal government to address some of those fundamental causes, as you called them, Magda, would have been nice to see. So whether that's unemployment or housing issues, expanding beyond just the immediate sort of HHS and make this a whole of government approach, I think ultimately would put the response in a stronger and ultimately hopefully more effective position. But nonetheless, Patrick, this was a wonderful change from the previous administration, which had focused so much on interdiction and enforcement. The other comment I would say is that the document itself has these 4 pillars and then guiding principles. If you look into the detailed strategy, there are principles around things like data and evidence and also equity. And I like to see the focus on health equity and racial health equity as a guiding principle specifically. I think what I would like to see next is a clear articulation of, okay, that is a principle. Now, what are the specific programs that the federal government can put in place or support states enacting to actually address and mitigate these vast racial health inequities when it comes to addressing drug-related problems. So I think it's a good step to see it as a principle. What I'd hope to see next is some enactment of that principle and actually support for programs whose goal is to address those issues clearly.
I would say that, acknowledging the emphasis on harm reductions and some new things was great, but I would say overall I was underwhelmed. Because I think, the truth is that, at least in the documents that I reviewed, that, that some of the efforts are, it's nice to see them consolidated there, but they're not actually new.
Yeah.
Some of them are honestly long overdue. Like they talk about the fact that, the FDA finally in July 2020 recommended co-prescribing of naloxone to patients prescribed prescription opiates and medications for opiate use disorder. So, I mean, that's great, but it's so long overdue. And to sort of put it on your new website was a little bit of a, it's nice to see it consolidated, but I think I'm perhaps a little bit more jaded. And I think one of the things that's problematic, that I like the point that you made, Brandon, about comparing it to the climate policy, because I think, and what, Jennifer's point around what happens, and I know this is one of our questions about the impact of the drug policies on children and families. And what we really see is a lack of coordination right? So, and that's what you sort of see on this page is you see these independent people working, but to what extent were these truly collaborations where we're aligning on what our goals of these policies are, and mapping that out. So this could be a step in that direction, but really trying to see some cross-cutting policy and agency work, which I think is going to be important to that.
So that's really great. And let's keep at this idea of sort of fundamental causes. So a lot of the stuff we've talked about today is very end focused, right? How do we prevent people from dying from an overdose? How do we manage sort of the outcomes of some of these markets? But, you know, as has been brought up, you know, to what extent are we looking at this primary prevention piece? But if we had our ability to like influence at a large scale, what are some of these fundamental causes we might go after, and what might these look like? And while I give you a second to think about this, because we're now off script, I just want to remind those who are in attendance that, you know, we're sort of into the section where please invite your questions in, put them into the chat. We'll start filtering those in. And hopefully that brief 20 seconds was enough time for our panelists to come up with how they want to change the world in terms of sort of fundamental causes and primary prevention. And I'll just open that to anybody. If given your druthers and your funding, what do you think we should go after?
Well, I'd like to start with the fundamental problem of addressing these the upstream issues is that we can't make these changes in the 4-year political term, right? So, you know, really trying to better understand how we motivate policy and politics, because these are, you know, longer term questions, right? That we're not going to be able to see. You're not going to invest, you know, in year 1 of your political term money in prevention and see that return on investment before you're up for re-election. And that really is sort of, you know, one of those key problems I think that we're going to have in addressing prevention. But it's, you know, I mean, I think it's best to say, frankly, prevention is not as sexy, you know, when you're trying to, you know, make drug policy changes. And so, you know, getting people to talk about these harder characteristics, how do we address poverty and despair and unemployment and fair housing, and understand that an early investment is really critical. And that's, you know, a harder sell.
Yeah, and in some of our work, we found, for example, that expanded access to healthcare. So, for example, with Medicaid expansion, that was associated. So, states that expanded Medicaid coverage experienced a greater decline in overdoses. So, you know, access to healthcare, a very basic right? It's not just focused on overdose; it's for everyone. I think that it could be a huge priority in terms of addressing this problem. I think, you know, we have an opportunity with some of the changes that were enacted during COVID to evaluate the impact of potential social policies. So, for example, the enactment of unemployment benefits, the adoption of housing eviction moratoria, the adoption of income supplements for families at a certain income level. All of those, you know, different states, different municipalities adopted different kinds of measures. I'd really like to see research evaluating the impact that these different measures have on drug use, on overdose risk, because it seems to me that those kinds of social policies are part of, you know, of the ways that we could address some of those fundamental causes. But we don't have a lot, you know, we don't have a lot of evidence yet. We know, for example, that places with greater level of underemployment, greater level of deindustrialization, greater risk for work-related injuries because of unsafe regulations, all of those places experienced an increase in overdoses. Now the question is, what can we do about that? I think with some of these new policies, we can evaluate and identify specific measures to address them.
Yeah, I think that's right, Magda. And I liked your point too, where it would behoove us working in this space to say, by doing some of this, we would anticipate benefits in terms of overdose and use disorders. But clearly there are many other public health and health benefits too. So maybe that's a great place to start in advocating for some of these fundamental causes and policy changes is to stay like, we have crisis levels of overdose now, we need to address that, but also there are many other ways to create a healthier society generally in the United States that addressing some of these fundamental causes would address. So I think, that's something for all of us maybe to take away from Magda's excellent point, is that yes, they would have benefits in terms of overdose, but many other health endpoints and health in general as well.
Yeah.
Right, the payoff could be huge, right?
Yeah.
Cross-cutting.
Yeah.
Yeah, and linked to that, of course, is, which I know Jennifer knows it's a big issue in West Virginia, is addressing childhood trauma, right? So we know that if you children that have more adverse experiences and traumatic events have a constellation, they're at a higher risk of a constellation of health problems, not just mental health and substance use, so increased rates of drug use and substance use disorders. So really trying to, understand, I think we have enough data that, primary provision of mental health to children and adolescents is primary prevention of drug use. And a reinvestment in that, the prevention world, particularly depending on the age, but really understanding that for children would be, really critical and have tremendous benefits, I think, in terms of return on investment and issues that we could improve. It's a serious problem here. And then also really thinking about, in the context of intergenerational drug use. We had upwards of 70,000 overdose deaths. I think that's for 2019. So many of those people who have died were parents. So really understanding what that impact is on those children that are left without a parent, the grandparents and other extended family members that are trying to care for these. And then in some cases, the children that haven't, go into the foster care system. In West Virginia, we have over 6,500 children in foster care. And we absolutely, our system is broken. The federal government is suing the state around our ability to care for these children. So it's not just that we knew this before the overdose epidemic, but now it becomes even more really elevated and concerning in that population. And we have a real opportunity to change things for the families that have been impacted by opiate use disorders and overdose deaths. In addition to preventing, obviously primary prevention of these deaths is of critical importance, but really trying to understand how we can wrap around support to those families will be equally important in terms of preventing their transition to drug use and having opportunities to live healthier lives.
I'm so glad Dr. Winstanley brought up ACEs. I'm a psychologist and I work in family medicine, so of course I'm going to talk about that. But we are, everything that we've talked about today already is prevention for the next generation. If we keep people's parents out of jail for prolonged periods of time, if we prevent extensively long separations from the family, if we treat their parents' mental illness, if we treat their parents' substance use disorder, then the children who are growing up are going to be at reduced risk for substance use later in life.
I just got to say that might be like one of my new favorite phrases and a way to talk about this, that everything that we're doing now is prevention for the next generation. That's really nice. Oh, I saw an unmute, so I was giving it a moment there. Talking about fundamental causes, and as we sort of move forward, as a reminder, anybody who's in attendance, if you have a question, please feel free to put it into the chat. And panelists, if you got a burning question for some other panelists, this is also a moment where if you're interested, you can put it up. While we're again thinking about this, there was a comment earlier on when we were talking about our very first question about prescription drug monitoring programs and sort of this shift that happened with chronic pain patients sort of getting pushed either into the OUD care system or just out of the system entirely. To what extent, and the part I want to focus on here is there's a piece here in that question that asks, how do we ensure that people who are affected by these policies are involved in their development? So how do chronic pain patients have a place or a seat at the table to discuss how the policy is going to change prescribing? Do people who are using drugs have a spot at the table for large scale policy changes like Measure 110? What are some of the mechanisms to think about this? What is done well? What's not done well? Where are we going forward for this? Just how do we ensure that the stuff that we develop, that we think about both for research and policy, that we're listening to the people that are involved in this, so we can avoid, some of these miscommunications that have come up, or these situations where we're suddenly totally upending people's lives because of policy that made sense, but if we'd listened or talked to a little bit more, we might have dodged some problems.
I want to address it by actually sharing a personal experience, which is right before I moved to West Virginia, I went to actually one of the FDA's hearings on naloxone. So this was thinking about 2015 or 2016. And I have to actually tell you, it was the public comment section that really honestly radicalized me in overdose prevention, because it's hearing those personal stories, and that's where we kind of sometimes get a disconnect, right, between our policies and our research, is when we aren't really listening to the people that are impacted. And actually, anyone who's interested, you should go back and read the transcript. I used to actually share exact text from the transcript when a parent was saying directly to FDA and other policymakers about the experience of why didn't I know about naloxone the first time my son overdosed, the second time my son overdosed? This drug has been around as long as I've been alive. And so, to hear the frustration of parents to say this is available and no one told me, it was so shameful. I mean, it really was dramatically shameful. So I'm really encouraged, though, to start to see that, at least in research, in drug research, which I think is important, and my colleagues on the panel might have opinions too, really beginning to see an emphasis on having community advisory boards, having representation, because I think, that's part of what happens, is getting folks more involved, the people directly impacted, patients, family members involved in the research process, understanding, elevating the importance of things like patient reported outcomes, right? We've always, more highly elevated objective, clinical reports, but really understanding the patient perspective. How can we deliver patient-centered care without knowing what the patient wants? I mean, these are some really basic questions. The NIDA has a new grant system that they're going to have on pain and opioids. It's called the Empower Network. And I've been actually quite pleased to see that there is an active voice from day one of people that suffer with pain and have an opiate use disorder, because those voices need to be heard throughout the process. So at least that's a step in the correct direction, I would think. And I know that there's significantly more that we can be doing.
Yeah, I agree with all of those excellent points. I would add one thing, which is that, from a researcher perspective, I think we have to understand why it can be so challenging for people who are actively using drugs, or for people who have lived experience or in recovery, to engage. We've heavily criminalized this issue for decades and decades, and so it's not. And there's so much stigma that it's not necessarily something that people are willing to shout from the rooftops about. There's a lot of trust that needs to be built there. Right. And it's, I think, the researcher's responsibility to take the lead on that and to build that relationship, and to acknowledge that there has been a lot of harm done in the past. And so that's one thing. I think the second thing is that we need to pay people for their expertise. So we have to acknowledge that they bring expertise, and then compensate them appropriately for their time and their insights. And so that is a continual process, I think, is also just not a one-time transaction. It's about building that relationship, and then acknowledging that expertise, and compensating that appropriately. So those are just two insights that I've had sort of working here in terms of how to do that effectively. But honestly, I do think myself and others, we can always do better as well, and to continue to learn from people who are experts in their own lives.
Yeah, I think there's a great opportunity with all of these new policy changes to think about how we can involve communities with lived experience, people who use drugs within the research, right? So as we're thinking, so for example, today the NYU Center for Drug Use and HIV Research sponsored a seminar on Oregon 110, and Jules Netherland from Drug Policy Alliance and Alex Kral from RTI were talking about principles to evaluate Oregon 110. And the whole thing was about how one of the key principles was how do we involve people with lived experience in this whole evaluation process in terms of formulating the questions, thinking about what exactly we're measuring, and doing the actual research. So I think having those as central elements when we think about how do we do these evaluations so that they're maximally informative and so that we can understand what is it that we should be measuring, what should we care about, how are these policies affecting people, who's benefiting and who's not, is really critical.
Just given a beat to see unmutes or not, and see how people are basically hands up is the unmute at the moment. Fantastic information about thinking about this, how we involve everybody along the way. So I want to sort of draw on something a little bit that's come up in a lot of the discussions today. We've talked about, racial equity or dealing with past racial discrimination, and in the US, it's a highly racialized society. And particularly when you look at the history of drug policy and drug laws in the United States, there's really not a single drug law back into the 1800s or before that wasn't in some way dealing with classifying a group of people based off some observable characteristic, sorting them into a system, creating a hierarchy around it, and saying substance use of a specific type is associated with this group, and we're going to penalize this, or we're going to treat them differently. You can go back to the early alcohol laws, the shifts in the statewide laws before the federal prohibition in 1914, all the way up through the current era where you see differences in how cocaine was handled based off who was presumed to use it in the 1980s. And today we think about charges of how the response to opioids, overdoses, and crises in different parts of the country with different presumed groups of people who were using them is offered differently and with different levels of compassion. Often we see that contrast between, the response in the 80s, which was maximum punishment across the board, to now we're talking about harm reduction, primary prevention, we're talking about decriminalization. So we live in this racialized society. We've seen this in drug policy and history through, 150, 200 years in the United States. So how do we think about this with developing new policy? How do we develop stuff that addresses this, that doesn't just reinforce this hierarchy moving forward again and again? And, I'm just really curious to hear the panel's thoughts on this, either in your own work or the research we do and moving forward. What is the way forward with this? Is recognition enough, or do we have to do more?
One thing, Patrick, I've liked a lot today is the focus on this idea of looking at who benefits, right? So we have been talking about new resources, a new focus on, say, harm reduction or new treatment resources. One thing we can do as researchers is to map and evaluate who is benefiting from these new financial or other types of resources, identify how those may be, exacerbating historical inequities, and then try to carve a path forward for addressing them. So for example, one thing we've done is to actually look at the OUD treatment landscape in the US, and we and others have showed that even access to treatment is highly racialized in terms of what treatment resources are available in specific communities. So this is kind of getting back to my earlier point, right, is where through policy we could explicitly identify that and try to correct some of those existing inequities that exist in terms of access to evidence-based treatment. And I think without explicit focus and thought around that. A lot of these new developments or new policies, be it decriminalization, full legalization of substances or new resources, unfortunately, because of this history and the current structure of US society, will just exacerbate inequities. So I think this needs to be first and foremost in a focus in terms of research, and then also enactment of new policies or interventions.
It really raises the question too, whether can we address racial inequities without tackling, without addressing criminalization of drug use?
Yeah.
They are, you know, it is really, I'd like to, can I ask the panel a question? I mean, what do you guys think? You're working in this space in drug use. I don't know that we can, but I'd be interested in what you all think.
Well, coming from the maternal health world, everything that we are doing now for moms who are in recovery from opioid use disorder, we knew to do in the 80s for cocaine use disorder. We were not doing it because of who was, as you said, presumed to be using the drug. And so you almost cannot disentangle criminalization of substance use and African-American in particular, and other minorities, but particularly we're talking about African-American folks. And I think that's why it's especially important, as we've been talking with other stakeholder groups, that they be involved in these discussions, and not just involved, but believed. You know, I have a lot of patients who their pain, their self-reported pain and pain threshold and experience is not believed at all. And I think a lot of it has to do with the assumptions that other people make based on their appearance.
Yeah, I think decriminalization, legalization is one step forward in addressing that. But I also think that without having a social determinants of health framework to decriminalization, say, or to any kind of policy, I don't think we're going to change those inequalities. You know, I think, you know, from the data that I've seen, even with marijuana legalization, there's still persistent racial inequalities in arrests, even after legalization, right? And I think that's because there are these fundamental causes, right, of racial inequalities in everything, in every aspect of life, and every kind of health condition. And so I think we need to think about these policies in conjunction with what are the fundamental causes of these inequalities, what are the social, the structural, the economic causes of these inequalities, and thinking about when implementing these policies and evaluating them, what are the other kinds of social economic policies that need to be enacted at the same time to address these underlying social conditions that create these inequalities. I'm a little bit optimistic that is happening. I know I'm part of a working group for the National Academy of Medicine, where they're trying to push for the social determinants of health framework on how to address opioid use disorder. So, you know, and I've seen that at different levels, and that's great. But I hope that is just the beginning of a shift in our thinking about drug policy.
Checking the time, I think we have about 5 minutes left. I haven't seen new questions in the chat. I've still got a couple queued up. Are there any other questions that the panelists have for each other, or is there something that you really hope to talk about that we didn't get to, or you want to really draw back down onto in these last few minutes that we have together?
I have another burning question. Sorry, I love this topic. Magda, I don't want to put you on the spot, but there's, given your work, and you might be the best person, other folks might want to respond too, but I'm really interested, you know, I think it was about a year and a half ago, there's a lot of discussion about the extent to which in areas that have legalized marijuana, that, you know, people could be moved, transitioned from prescription opiates to marijuana. And I don't know how much of your work is at that intersection, but it's going to be such a critical question, I think, from a public consumption of science, right? Like, to what extent is this going to be a good thing? I have my own opinions, but if your work is focusing on both, I'd love to hear what you have to say, because I think there's kind of a disconnect between where the science is at and where the public is at. That's not even policy, right? Like public opinion is somewhere, policy is over here, and science is, I don't know, I think science is like maybe down the street.
Yeah, that I think, it's such a, we're grappling with that question right now. So we have a study to look at how, the joint enactment of policies that regulate the prescription opioid supply and liberalize access to cannabis, how those two interact and affect use of opioids and overdose and prescribing. And it's a difficult question. And so our hypothesis was indeed, right, like if you cut off or if you reduce the prescription opioid access, but you increase access to cannabis, is that going to lead people to transition to using cannabis or to initiating cannabis rather than initiating opioids? And is that going to reduce shift to heroin and to synthetics? I don't think yet there's a clear answer. So there were a few papers that showed a decline in overdose in states that legalized recreational use of cannabis. But then there was a more recent paper by Chelsea Shover that suggests that that might not be the case, or that the effect might vary over time. We're trying to understand that now and looking at, what's the specific impact of laws that increase access to medical use of cannabis versus recreational use of cannabis. Some of our findings suggest that perhaps states that provide the most liberalized access to cannabis, those states may experience a greater decline in overdose, but the findings are still very preliminary and we're still trying to understand them. So I don't think we have a very clear answer yet. And the challenge also with these laws is that A, they're very recent, and B, they're enacted with so many other laws, right? And so it's really hard to figure out what is the cannabis legalization effect and what's, the naloxone access law effect, the shift in the fentanyl market. So we're trying to grapple with all of these confounding factors at the same time. We hope to have an answer soon, but not yet.
Thanks, I appreciate it.
Sorry, I was on mute. Yeah, it's a challenging piece. We just did publish one study that Magda was involved in here in Rhode Island, where we linked PDMP data and medical cannabis licensure records and did not find changes in opioid prescribing after someone received a medical cannabis license. But there was a lot of limitations to that study. We didn't have a lot of other data or information on diagnoses necessarily, reasons why people were using prescription opioids and so forth. There were some limitations there, but a lot of interesting work, I think, that could and should be done around this as the policy landscape changes.
Absolutely. So I just want to draw a quick attention to, we got a brief side question for the panel. I'm not sure if I know the answer to this either. What are the technical terms for what is colloquially referred to as marijuana maintenance? Someone's trying to get a little bit more information, and it's curious if we have better search terms for them. I'm not sure that I do. Any of you? No, sorry.
I am not familiar with that term. No, I am. My apologies. That's a new one for me.
I think we'll all be doing a little bit of research on our own on that one. All right, so I think we're about time. I'd really like to thank all the panelists today. This has been fantastic. I really appreciate your engagement today, as well as in the lead up to this. You've all been a dream to work with as far as being engaged and sending stuff back and forth, and I really appreciate it. And for all of our attendees, I hope you had a really great time listening to this expert level discussion about a whole range of things, and I hope that it's been an informative process for you all.